Hello students, in this session I am going to discuss here an overview of the lower limb. In fact, it is not just the lower limb. In any region, when you start any region, like you start the lower limb or the upper limb, thorax, abdomen, pelvis and perineum or head and neck, in these all 6 regions, whenever you will actually enter, you have to pick up the things like you have to discuss any region under 9 different components. Any region, this is not just lower limb. We are taking the example of lower limb because you are interested here with the lower limb now, but in any region, this applies to any region. That means in other regions we might not actually give this class an overview of that region. Maybe we will give, but you see that this lower limb an overview means we are going to teach you here that how to take anatomy of any region that you are in. Here you are dealing with the lower limb. So, in lower limb or in any region you have to pick up and you have to identify there are 9 basic fields, 9 basic compartments or 9 basic components, rather not the compartments as such, basically 9 basic components which you have to take one by one. And in these components you see that you have to pick up first the osteology, I see the bones of that region. This is most important, and the first thing you see that when you are actually dealing with any region, the first thing that you will come across is the skin, then is the fascia, I say superficial fascia, then is the deep fascia, but I suggest that you should start with the osteology, bones of that region. Reason is that because when you actually discuss the bones of that region, and when you will complete all the bones of that region, you will have a good idea how much is the extent of this region. That means bone is forming here the framework of any region. So, when you will actually complete all the bones, you will have a good idea that the region extends from this area till this area. That means this is the region and we do not have to actually trespass. And this is something that is the osteology or the advantage of the osteology, and we will tell you that how to deal with the bones of that region. You know that in many setups, usually the regions are dealt with, like for example, if you take any part of your lower limb for example. In the lower limb they take obviously the thigh, the leg and the foot. These are 3 major regions. 3 major sub-regions of any region is like for example in a lower limb is the 3 regions, you see 3 sub-regions, the thigh, the leg and the foot. But when you enter into the thigh, in the thigh again you will actually see here there is the thigh is anterior surface, basically you see more precisely anterolateral surface. It has the medial surface and it is the posterior surface. When the posterior surface of the thigh you are discussing, you will see there is a gluteal region also. Whatever the regions are, so these are the sub-regions. In sub-regions there are sub-regions, you see that there are certain compartments you can say. So, in any region there are sub-regions, in sub-regions there are the compartments. Now, this is up to you whether you will take each compartment full, all the 9 components of that compartment you have to take, right. For example, if for example you are taking the anterior aspect of the thigh, you have to take 9 compartments. I say you have to take 9 components of that region. I told you that in any region, if you take the entire lower limb, so you have to actually go into the interior, as in the thigh, in the anterior thigh for example, in the front of the thigh. In the front of the thigh, when you will enter into the front of thigh, I told you that you have to deal with the front of thigh under 9 components. When you enter into the medial side of the thigh, again under 9 components, and the back of the thigh again 9, and the gluteal region again 9. So, what are those 9 components which you have to deal with in any compartment of any sub-region of any region? Like for example, this is the lower limb, it is the region. Then is the thigh, it is the sub-region. In the thigh, the anterior thigh, this is its compartment. In compartment, I will actually deal with 9 basic components to deal with the anatomy, the basic anatomy I say. Because we will tell you that anatomy is not just basic, you have to do the clinical correlates, you have to practice the MCQs and BCQs also, and then you have to present a case also. This is called the case presentation, and according to the case presentation you have to deal with the answers. But answers you will be able to present, or you are able to give only when you have a basic knowledge about that. Basic knowledge is must. because you see during anatomy course, if you don't have any knowledge about the basic of that region, you will not be able to judge, or you see able to assess the problems which are dealing with which are actually happening with that region here. Any disease concept you will be able to understand only when you have a basic knowledge about that. Normal thing is must, because you are in a region where you are dealing with these things for the first time, and if you don't know about the normal, how you will be able to understand or discriminate between the normal and abnormal. So don't jump upon, you see that, don't jump to the conclusion and go to the clinicals fast, you see that. You don't go to the clinicals until you have got a good knowledge about the basics. Basic is must here. You give more time to the basics. Clinicals actually will be repeated, you see. When you will go to the third year, you will do the pathology. Again the clinicals. When you go to the fourth year, again pathology comes. In the final year, there is a medicine surgery, there is orthopedic ophthalmology, everything is abnormal, everything is a clinically correlate. But the clinical correlate you are able to understand when you have got the basic, and basic you are dealing here in the anatomy. Because in third year, you see, when you go to the third year, will straight away they will write, for example, the fracture of the femur, for example, or in the final year will they write the fracture of the femur. Here they will not give you the anatomy of the femur. So that piece anatomy of the femur you will have to do here in your earlier class, in the first year and the second year classes. So here I told you that when you are reaching here in a region like, for example, the lower limb, its sub-region, that is the thigh. In the thigh is the compartment, there is the anterior compartment. Dive into the anterior compartment and watch there and deal with that compartment with the 9 components. Out of these 9 components, there will be bone is first, osteology of an interior region. You see an interior region, which osteology? You have here femur, you have the hip bone. So these 2 bones are there. The aspects of the hip bone and the aspects of various aspects of the femur you have to do. I will tell you that how you have to deal with that, but you see this is the femur and hip bone, this is osteology, landmarks, everything. Next thing that you have to do here is the fascia, and now you return back and you see the skin and the fascia. This is the second component, we will show you this in details. Second component is the fascia and skin. Third will be the muscles. What are the muscles which are present in the interior compartment? We will tell you in details how the muscles are dealt. We will not do the muscles, I will tell you in overview how the muscles are being dealt here and how the muscles will be actually solved, how you actually have to understand the muscles. Then after the muscles, you have to see when the muscles are passing here over the front of the thigh, incidentally some spaces are created, they are natural spaces, and you see the natural spaces. So watch here spaces, and these intermuscular spaces and other spaces you have to deal, their boundaries, etc. you have to deal with. This is the fourth component. In the fifth component, you have to actually go and you will see the neurovascular bundles. Once you have done in the anterior compartment of the thigh all these 4 components, then you enter into the neurovascular bundles. 4 more. Neurovascular bundles means you have to deal with the arteries. First arteries, don't go to the nerves first. We see the arteries, then the veins, then the lymphatics, and the last will be the nerves. So 4 more components you have to deal with them, and the last will be the joints. 9 components in any compartment of any sub-region of any region you have to deal with this here. When you will be actually you have having completed all these things in 9 components in your anterior thigh, you go to the medial side, again repeat all these 9. Bone there, fascia and skin there, muscles in that compartment now, then intermuscular spaces if there are any, then the 4 neurovascular bundles will be there. So arteries, veins, nerves, and lymphatics and veins. And then last will be the joint if it's there. If it's not there, leave it. So that means these 9 here. Then you go to the back of thigh, but before back of thigh you have to deal with the gluteal region. So when you will actually go in each region, you have to take the 9 components here until you reach the sole of the foot, and again 9 components means the skin, superficial fascia, as a osteology means articulated foot, the various bones of the foot. Then you have to deal with say skin and fascia. If skin and fascia is different from elsewhere in the body, then you have to do specialization only in the lower limb if it is there. Like for example, deep fascia in the sole of the foot is cardioplantar aponeurosis, which is not present at other parts of the body. So it is present here, you have to deal with this because you have to deal with the pathology of this. Abnormalities which take place in the plantar, plantar aponeurosis, cardioplantar fasciitis. This is the fascia, this is the fascia part. And then you have to go into certain other things like you see muscles of the sole of the foot, very important, which are arranged in layers. Then you will enter into the spaces if there are any. Then watch here some more things like for example neurovascular bundles, artery, veins, nerves, lymphatics, and then last will be the joints. So, in any portion you have to deal with these 9 components. This is the one way to deal with any region, but my advice is do not go like this. Take 9 components surely, go to the region, this is true, but do not do all these 9 components at every region's compartment separately. If you take your lower limb, just see the lower limb from distance, go to the lower limb, do 9 components. The first component is the bone, but do bones of the entire lower limb first. You understand this? It is not like you take here the lower limb, anterior thigh, just the bone of anterior thigh. No, take the bones of the lower limb. Initially you take all the bones of the lower limb. It is not just the lower limb, it is all regions. You see, head and neck is very, very difficult as far the bones are concerned. Usually I suggest that you will take 1 week full, okay, do all the bones of your head and neck, do all skull, vertebrae, everything like. So here do all the bones of your lower limb. Number 2 component is the fascia and skin. Fascia and skin of the thigh, of the front of thigh or back of thigh, do all the fascia, skin, fascia, everything of the entire lower limb. Then enter into the muscles. No doubt we have got 70 muscles, do not worry about that. You have done the bones, the muscles will be very easy to tackle. Take the bones, you should take the muscles and spread the muscles in all over, in all the compartments. You take the muscles, means each compartment you take and take the muscles here together. Do not leave the muscles until you have done all the 70-80 muscles you of the lower limb here. Do not leave them. So this is actually called the myology. So that means osteology separate, then the soft tissue and connective tissue, etc. Now is the myology you have to do. Here is all the muscles of your lower limb. Do not do anything except you have finished all the 70-80 muscles of your lower limb. And after the lower limb muscles, you have to see here, I mean the muscles have already, you have arranged, fascia you have already done, bone you have already done, spaces will be created by themselves. And your boundaries will be formed if the space, if any space is there, boundaries will be formed by these muscles. So boundaries will be already done, you see that. So the spaces will be very, very easy for you to mark the boundaries of these spaces. And if spaces have been done, and now after these 4 components have been done, like for example, bones, fascia, muscles and spaces, believe me, you will consider that as if you have done all the lower limb. What will come next is their members which will live inside them. These are the neurovascular bundles. And out of these neurovascular bundles, take the arteries. When you take the artery, for example, spread these all arteries in the entire lower limb. Don't touch the vein, don't touch the lymphatics and the nerves here, just do the arteries here. I will tell you how to tackle the arteries. And after the arteries, you take the veins, because veins will be running along with them, but because here we have got the superficial group and deep group is separate here, so you have to actually deal with the veins much easier. Then the arteries. Then will be the lymphatics, even easier than the veins, because there are certain groups of lymph nodes, so we have to actually take them. This is our 7th component. 8th will be the nerves. Nerves have to be dealt with, like for example, in nerves of all the lower limb, right from above till below, you see that. Because one nerve, if you are taking, it will run here in the anterior compartment of thigh, may run into the in the anterior compartment of leg also, may run in the other compartments. So you will not wait that this nerve is running in the anterior compartment because I haven't done the posterior compartment, so I cannot take this nerve further until I will do this posterior compartment. No, do all the muscles first, and later on you will take the nerves and arteries. And these arteries, you have to take all the arteries, all the nerves, everything. Once you are now getting yourself comfortable here, last thing before leaving the farewell this farewell component is, this is called the joints. Next you take the joints. You see, very important here, you see, if you are taking the joints, you see almost half the joint, by the time you reach the joints, I tell you that half the joints are supposed to have been done. Unknowingly they have been done. Take for example, if you are taking any joint, for example, you see in the lower limb you have the hip joint, you have knee, everything, and you have ankle and some other joints also. So you take for example, if you take say articulation, how the joint is formed, already you have done the bone. You know that is upper end and lower end and they will join together, which components and which articular surfaces you already know. As far as the capsule is concerned, you will actually attach the capsule, ligaments, their attachment above and below with obviously with the bones, landmarks you have already done. And then the muscles, which muscles and which movements they take place and which muscles they are doing them, your localization of the muscles already you have, and you will pull the muscles, you see which movements they are taking. These are called the joints here, and joints once you have finished, this will be finishing your first phase of the studies with the 9 components basic anatomy you have done. And after that you enter into the next phase, that is the clinical correlates. Do not take the clinical correlates initially, just do them just as if you are actually doing ABCD, are just simple sentences with the basic tenses you are doing. It's just like this. But after that, now the complex thing will be the second phase, and second phase, once you have done all the basic anatomy of the entire lower limb, now you will actually be putting them into the clinical correlates. Clinical correlates of the bones, again 9 components will be take, but they are clinical correlates this time. Normals you have seen. Clinical correlate means fracture of the various parts of the femur, fractures of the pelvis, fractures of the tibia, which parts and other things you see, that this is called the clinical correlates of the bones, and then of the fascia. In the fascia you will see various canals, etc., like here femoral hernia, this and that you have to take, because you have already visited here. That's why femoral hernia will not be as difficult as would have been in fact previously, before you had in fact taken this. So this is what we call here the clinical correlates of all the 9 components. This is second phase of study, and by that time you will be feeling yourself comfortable that you have done with the lower limb, and you can identify the diseases of the lower limb. A patient comes to you, at least you can identify. Treatment is not your business. Treatment will be after you will enter into your final year. But first you know these things here. That's why it is the 5-year program. It's not actually 2-year program. If you know everything after the second, in the first year, if you know about the fractures management, then after first year, second year, you should be awarded the degree. So thing here is, this will be actually like you see this called the clinical correlates. The third phase of study is the clinically correlated, I say clinically scenario based clinical questions and basic questions, MCQs you see that, or the basic, this is called the base choice questions here, where the 5 options will be, questions will be projected and 5 options will be given, and you have to pick up one answer. And we will tell you that how to deal with this also. And after that, the fourth phase, the good phase, you see that if you go into that is much better. It's my advice is that should actually tackle this phase also, that is called the case presentation. At least 1 or 2 cases related to that, related to the bone fracture. A case should be presented, the patient of that age, he has suffered this injury, he has been brought to the clinic like this, his symptoms are like this, during examination we have in fact found these findings, and we have actually written these investigations is bringing these positive signs and positive findings here. Using your basic anatomy, now answer the following questions. Logically you should answer the following questions. So questions will be written below. 5 or 6 questions should be written there, and using your now technical language or technical, I say know-how that you have already done, like for example the basic knowledge, clinical correlations, some practice about the clinically oriented questions, and now clinical presentation. During this clinical presentation, during that whole process, you should have good idea about the surface anatomy as well as the radiology of your lower limb also, especially the bones. You see in the lower limb is mostly the bones, and some other things like CT scan and other things you will do. If you have done them in a basic way, I tell you, it's not this type of exam in our universities, but in any university, there is nothing beyond that. In lower limb, always there is a thigh, leg, and in any part of the universe, if you will go, human being has these regions. They have the common problems. Though the frequency or the incidence is more and less in other societies here and there, but you see problems are same, as almost management is same also. In any type of exam, you will be feeling yourself comfortable. Nothing new has to be added actually in your syllabus afterwards, after you have done all these things. And you will be ready for your USMLE, you will be ready for your PLAB or any type of exam, let alone this exam. I say any type of exam you will be comfortable. And I tell you that if you are doing this, lower limb should be done once and for all. When you are leaving now your first year, believe me that you don't have to add even 2% or 3% of your additional thing you don't have to add in your lower limb, except your experiences, the things that you have actually heard from here and there, new knowledge, information, you keep on actually adding them. So when you are taking notes, you are bringing here a book here, for example, you leave some pages here deliberately so that the new things should be actually added. You should just add them, otherwise basic things are same. Nothing new will be added here. A muscle will be same. Now you have seen something new in that muscle, some new symptom has been brought here. So you will actually write your experience and you see, take knowledge in here and there. So bring actually like this here, and once you will compile your book or compile your notebook, for example, keep that in your cupboard, don't touch it until it is required again. because the lower limb will actually, this will be brought back again when you are entering into your other classes. Like for example, you go to the pathology, you go to orthopedic, same lower limb problems will come back again here. And if you go again to your, for example, the books and others, fresh other books and these things here, it will be very difficult to deal with, because you have already formed a notebook. So bring the notebook and see the index of the notebook and the contents which you have already written on your initial pages here, find out them and read just in 2 minutes time. It will be repeated. So once you leave your first year is not left, first year will follow you. You will actually, it will follow you, because these all things in fact will come in other years also. If you are doing here the anatomy of the eye, that does not mean that the eye you have done in the second year and after second year you will forget about the eye. No, you will go to the ophthalmology, you will see this anatomy of the eye back again, and now is the pathological, and then is the management, and other things will be there. So you see, once you are a medical student, you will remain always a student, and these things actually be dealing here. And now I will present here a slideshow in which I will be dealing here with an overview what you will have to deal and what you will see and how you have to deal with these things here, whatever I have actually given in this session, in this discussion here. Let us watch. So this is an overview of the lower limb, and I have already told you that in the lower limb you have to actually tackle these things and under 4 phases basically. The first phase is the basic anatomy. Second phase will be, the clinical correlations. Third phase is the BCQs practice, and fourth is the clinical presentation. So we are dealing with here the first thing that is called the basic anatomy, and I told you that the basic anatomy means you have to see 9 segments of that region, 9 components of this region. This region means the entire lower limb, this time not just the thigh anterior or thigh posterior, no, entire region means the bones first, skin and fascia second, muscle third, space in that sequence. Sequence will be this, then arteries 5th, 6th is veins, 7th lymphatics, and the 8th is the nerves, and last will be the joints. These are the 9 components of a lower limb or any region you have to actually tackle here. Now for example, if you are going into the bones, for example, bones, you take up one by one the bones, like for example, in all the bones, for example, you are taking the bones. I told you that you take bones, how you will have to deal with the bones, we will tell you. Skin and fascia you will take, muscles also, spaces, arteries, veins, lymphatics, nerves, and then the joints. Go to the bones first, bones of the entire lower limb, and you have already seen when you are taking the bones of entire lower limb, or just see them, you have to take the, if you take each one by one the bones, which bones? Like the hip bone first, next bone is the femur, then is the tibia, then fibula, then is patella also, and then will be the articulated foot. Not the foot bones separately, you will be actually provided with the bone, the foot that is actually articulated. We have the tarsals, metatarsals, and the phalanges articulated. You will not be actually put here on the table the calcaneum, you say the various surfaces of calcaneum, which side of calcaneum is, no, articulated foot. You know that articulated foot is like here, so you have to do the articulated foot, but in any bone you are taking, what you have to deal with and how and what you have to actually do in the bones. The first thing in the bones you should do various parts of the bone, how you determine the side, because you usually on the table you have the bones, always you have the bones which are actually separated from the human being. They are actually the bones of the dead bodies or the cadavers. So you see the bones of the cadavers, or you have the artificial, I say artificial bones, you have the bones. So the bones are not actually with the patient, the bones are in your hands. So side determination usually is asked, and you have to deal with how the side determination, and then each part of each bone which you have taken, each part of each bone that you have actually taken, you have to identify the major landmarks of each bone. You just identify them. For example, if you have for example, take the example of the femur. The example of the femur if you are taking, or the example of you take the example of the hip bone. And hip bone we have various parts, we have ilium, we have pubis, we have ischium, these are the parts. But in each part, for example, you take various landmarks, you have iliac crest, you have anterior superior spine, anterior inferior spine, posterior superior, these are the landmarks. All the landmarks which are present here, which will be used in future, this will be referred in future, they will be referred also. Each landmark, no attachment is required here. You do not have to see the attachment of the muscle or ligament here, no, just identify them, feel them and see each parts of this landmarks which are actually present. If you are seeing here the iliac crest, for example, the iliac crest is the outer lip, the inner lip and the intermediate surface. You should actually be feeling them. You should have you should feel here anterior superior spine and you should feel the area below the anterior superior spine. You have the pubis bone has its symphysial surface, it should have the body, it should have pubic pubic tubercle, it should have pubic crest, etc. All these landmarks you should identify only, no attachment is required at that stage. This is something when you are actually done here, all the bones that will take not more than 2 days, maybe in just 1 day is enough for that, the bones here. So, bones means your parts of the bones, site determination, identification of major landmarks of each part of each bone, and then if required, if clinically important, then ossification also. After that you enter into the fascia of the lower limb. Fascia of the lower limb, skin and fascia. I say in skin and fascia what you have to take in lower limb. First of all you see the skin. Skin is identical, skin is just like generally it is just like structure of the skin is general and just like elsewhere in the body. So, we do not have any specialized thing here in the skin as such, but if you cut the skin and you see the superficial fascia, we do not have any superficial fascia specializations as such, it is filled with the adipose tissue etc. But when you clean the superficial fascia and you watch the deep fascia, that is very important in your lower limb here, especially the deep fascia of the thigh, its name is the fascia lata, you have to do it. On the lateral aspect of the fascia lata, you will see that there is a very thick band of the fascia lata which stretches above, attached above with the iliac crest and below it is attached here to the lateral condyle of the tibia front, that is called the iliotibial tract. So, iliotibial tract is a part of deep fascia, you have to do it. And when you enter here into the deep fascia, you can remove the deep fascia and you watch here the very important fascial covering that actually is being drawn into the thigh by the progress or by the entrance of the femoral vessels, which were actually abdominal vessels previously, but once they have entered into the thigh, their names will change to the femoral vessels, and these femoral vessels will take the abdominal fascial coverings downward into the thigh for a few inches here. This is called the femoral sheath, you have to do the femoral sheath. So, femoral sheath is again important. So, femoral sheath, then in the femoral sheath you will see femoral canal also, that will be actually space, but you have to do with the femoral sheath, the femoral canal. Then after femoral canal and the femoral sheath especially, there is a fascia again between the two bones, you call them a membrane, we call them interosseous membrane. After interosseous membrane, you see when you come into the leg has the fascia also, its name is the crural fascia. This leg is the crural fascia, again important. But in the crural fascia will come under the foot here, deep fascia of the foot. And the deep fascia of the foot, especially we see the deep fascia of the foot when it comes here into the central part of the deep fascia of the foot. In the sole of the foot it becomes very tough, a triangular tough band of the fascia, just like in the lateral side it was iliotibial tract, and here it will be called as plantar aponeurosis. This is plantar, this is nothing but the deep fascia. On the sides is not as tough as the central portion is very tough, that is why its name become separate, it is called plantar aponeurosis. But especially you see that these things here, you see these bands of deep fascia. All deep fascia everywhere has been removed, but these bands actually they persist. These bands are called, especially these bands are present in the upper and lower limb, where in upper limb between the hand and the forearm, and here between the foot and the leg here. These are the bands, and these bands are attached with the bones here, and they are leaving the space underneath them, and under these bands, whose bands their names are the retinacula, we call them retinaculum. And here in this anterior aspect we have got these retinacula, these are called peroneal retinacula, superior peroneal retinaculum, inferior peroneal retinaculum. These are nothing but what? These are the modifications of deep fascia. And you see these are called
these are called the extensor retinacula, but these are on the anterior aspect of the leg here, at the junction between leg and the foot here, at the region of ankle. On medial side you have got another retinaculum, under that you see flexor tendons are passing, these are called flexor retinacula. This one here, this is called flexor retinaculum, a single. Then you are watching here on the lateral side you have got again a very complex structure that is again called peroneal retinacula. They are the superior and the inferior. Superior and the inferior. Inferior is actually having a two separate compartment, but superior has just single compartment. These are called retinacula. So, plantar aponeurosis, retinacula, iliotibial tract, femoral sheath, and all these things you have to deal with in the fascia of interosseous membrane. Not only this, but here one more structure that you see, one more anatomy of this here. You see the D fascia surrounding their thigh, and the D fascia is sending the septa inside, so that the inside of the thigh should be divided into the intermuscular compartments. These are called as septa. So, septa you should actually be discussing here, how the septa enter into the thigh or into the leg, and separating the region into the subregions, various compartments we call them. So, this is called intermuscular septa. They are very important, because septa, when you are actually showing you separate compartments, so each compartment will have its own group of muscle, own artery, own vein and own nerves here. And these are represented like here. See, this is anterior compartment, here these septa, they are important, and you should know that these septa come from the D fascia surrounding the leg or thigh, and they come inside here between the muscles, and they will get fixed with the outer surface of the bone, and bone has the facial covering. I say bone has the D fascia, I say covering, that is a fibrous tissue, connective tissue, tough covering, that is called periosteum. So, that will be fixed with the periosteum. Not only this, but at the same time you see when the tendons were passing, you see when the tendons of the long tendons were passing under the retinacula. So, to minimize the friction, nature has provided here another facial coverings in such a way that the facial coverings contain the fluid inside. This is called the synovial fluid, and these facial coverings are called the synovial sheaths. So, all the tendons, especially those tendons which are crossing the ankle, which are passing under the various retinacula and various compartment muscles, which are passing in the retinacula at the various aspects which are present here. And here this side you see lateral side, we have got a peroneal retinaculum, we have got this extensor, on the other side on the medial will be the flexor retinaculum. So, all the tendons which are passing under them, deep to them, will have actually synovial sheaths which contain synovial fluid to in fact lubricate them and minimize the friction here. These are called synovial sheaths, you have to take them. Then and then I told you that, so this was the skin and fascia. So, what you will take in the skin and fascia? I told you that it will be the D fascia you have taken. Any specialization in the D fascia you see, like iliotibial tract, like fascia lata, femoral sheath, like you have seen retinacula, plantar aponeurosis, synovial sheaths, you have to take them. So, retinacula and then some clinicals about them also. After that you will enter into the next session, that is called the muscles now, muscles of the lower limb, and you have already seen as far the muscles of lower limb is concerned, how you will take the muscles. You have to take the muscles in a way that you have to name various compartments. How many compartments you have seen? You have seen the thigh is the medial compartment, anterior, posterior, the gluteal region. Leg is the anterior, lateral and the posterior. Foot has the dorsum and the sole. So, we have got 4 plus 3, 7 and 2 more. So, 9 compartments in the entire region of lower limb you have, and each compartment has its own group of muscles. So, name various compartments, name of the muscles in each compartment. Not only this, but you can touch that muscle also. Surface anatomy of each muscle should be there. Surface anatomy, it does not mean you have to mark them, at least your hand or your forefingers will be over the muscle which you are actually pronunciating. If you are saying it is sartorius, you can actually touch your sartorius also. That does not mean you have sartorius in your mind and you do not have idea where the sartorius itself is lying. So, at least you should actually doing this also. So, you see this muscles like for example, anterior compartment, anterior thigh muscles, you are watching these green, this is yellow and all these muscles are anterior compartment muscles, anterior thigh. Watch another, this is the medial compartment, adductor compartment muscles. You are watching here, these are called the gluteal region. Above you see this is all muscles, gluteus maximus has been removed to show you minimus and medius etc. and other muscles here. Then you are watching this fourth compartment, this is called the posterior thigh, hamstring muscles we call them, the long muscles you see, travelling along the entire back of the thigh here and reaching up to the even upper part of the tibia and fibula. See, this is taking origin from ischial tuberosity. ischial, taking origin from ischial tuberosity. When I say origin from ischial tuberosity, means you have already done the bone. You should have the knowledge about the ischium, you should have knowledge about its major landmark, that is the ischial tuberosity. So, this is the posterior thigh, and now you are coming under the leg. This is the anterior compartment of leg, this green color muscle you are watching, this red color, all these are the anterior compartment. You see long tendons, they are passing under the retinacula to go to the dorsum of the foot. Then you have got the lateral side also, peroneal compartment, that is also called, this is called the lateral leg here. So, lateral leg is passing, as a lateral leg compartments, they are, as a lateral leg muscle, they are passing here laterally behind the lateral malleus under the retinacula and going under the sole of the foot. One can go to the sole of foot, but usually it is on the dorsum also. Then is the posterior side of the leg, which is called in calf muscles. Calf muscles, which you can feel here by yourself, is a very thick and bulky muscle is there. There is a superficial group of calf muscles, and then will be the deep group of calf muscles. Once you have removed the superficial, you will see the deep now. Sometimes they are divided into superficial, intermediate and the deep compartment, but usually it is simply you can call it the posterior, and I say the posterior leg is calf muscles, superficial calf muscles and deep calf muscles. And then we have got the dorsum of the foot. Dorsum of the foot incidentally has just single muscle. Dorsum does not have too many of them. You see this. So, dorsal muscle of the foot, and then is the sole of the foot. Sole of the foot is very, very complex. You see that sole, because your all body weight is on the sole, and sole is not directly on the bones you are your ground is touching. You have got a lot of things here. Very thick skin. As a very thick skin underneath superficial fascia will have the fat also, but a lot of deep fascia thickening centrally, deep fascia thickening, that is called plantar aponeurosis. And when you cut the plantar aponeurosis, you will have various layers. You have 4 layers of the muscle there. This is the first layer muscle, we will see them later. You see that is the second layer again. After that you see third layer, and the last will be the fourth layer, this one. This is the first layer, the second layer, third layer, and this is the fourth layer. Fourth layer muscles are there. So, 4 layers of the muscles will be there, and when you see the 4 muscles group, I tell you that you are doing what? In every muscle group you are doing the muscle group, you see, take the compartment, name the muscles, localize them, and then take each muscle now in that compartment. In that muscle what you will do? First of all, introduce the muscle. Some facts about that muscle, layman's language, if you see in the layman's language, discuss that muscle. Like for instance, ARTERIES is the longest muscle of the body, is the most superficial one of the 4 superficial muscles. Likewise, you see some features about that. Then you will enter into the real business, that is called technical thing, that you say origin of the muscle, where it is inserted, during origin and insertion, how it passes and what will be the relations around them, what will be the actions. And you see when actions will, if you know the origin and insertion, then you pull the muscle, you will see which joint is moving. Do it by yourself on your body, not necessarily on the model here. When your model is available, do it there also, and a skeleton also do it, but do it on your body also. See what is the direction of the muscle and how it can pull and what will be action on the joint here. Do it, every muscle you should actually do. So, this is what we call here the origin, insertion, then the nerve supply, the blood supply, or if it is contributing in any intramuscular space, and then its actions on the joints, and then some clinical correlates you will actually be doing here. This is the muscle. So, in one page you can easily discuss one muscle. So, 70-80 muscles means 80 pages you can write by yourself in just 80 minutes. Not 80 minutes, okay, in one day no problem, but you should actually have a knowledge about that. Then is the spaces of the lower limb. In spaces I told you that you have a lot of spaces, like in the front of thigh you have a femoral triangle. So, you have to do the boundaries of the femoral triangle. What is the roof, what is the floor, not the contents yet, contents will come in form of neurovascular bundles. But here you can do one content, that is the femoral sheath because you have already done that. So, see, this is what we call here the femoral triangle number 1. You have to do here the femoral sheath, and inside there was the femoral canal, this is a space again. Then in the deep fascia there was a space, that was the opening, that is called saphenous opening, a very important, you have to do this saphenous opening. Another is the adductor canal, another space between the anterior and the medial compartment of the thigh. Then in the adductor compartment or the medial compartment, in the adductor magnus muscle you have a hiatus, because hiatus is actually a gate through which the anterior neurovascular bundles will actually pass, because they want to avoid to pass in front of the patella. So, they will actually go back here to enter into the popliteal fossa. So, this is the hiatus which in fact will guide you into the back compartment of the thigh. This is called back compartment of the leg, is called the adductor hiatus, and then the popliteal fossa is another space that you have to see. So, all these are called the spaces. When you are doing any space, so you have to actually watch here in any space. For example, you have to see its boundaries, its roof, its floor and its contents. Here in this phase do not count the contents, because contents will come when you are entering into the neurovascular bundles, and in the neurovascular bundles first of all do the arteries. Arteries in your entire lower limb. I told you that entire lower limb will be the first artery, that is called the femoral artery. Then you have the profunda femoris artery, a very big branch of your the femoral artery. Then not only this, but do not leave and do not follow the femoral artery to become popliteal, go back into the gluteal region and watch here superior gluteal artery, inferior gluteal artery, you will see the obturator artery, again important. And then during this profunda femoris of the femoral and these superior inferior gluteal etc., all these arteries will join together to form the anastomosis. These are called trochanteric and cruciate anastomosis, again important. And then you will come back again and follow the femoral artery, which has become now popliteal artery in the popliteal fossa. Then popliteal artery, if you have done, then you see popliteal arteries branches, and then you see the anastomosis around the knee joint. Which arteries branches will contribute in that? And then popliteal artery will split into posterior tibial. You see the posterior tibial in the femur in popliteal fossa. It runs down here until it will split up into the medial and lateral plantar arteries. But one of very important branches of the posterior tibial, very early it will give here, that is called the peroneal artery. Peroneal artery is very important artery of the lateral compartment. And then you see in the foot medial and lateral plantar arteries, which are the branches of the posterior tibial. And then posterior and interior, as a medial and lateral plantar arteries in the foot will join together to form the plantar arch. This plantar arch is again important. But you come back again, you see the anterior tibial. Anterior tibial artery is the one of the terminal branches of the popliteal, which in fact leaves the popliteal fossa to come into the anterior compartment. You watch this. This is called anterior tibial, that continues on the dorsum of the foot. Will be called as the artery of the dorsum of the foot. You call them dorsal spidus artery. Clinically very important artery whose pulsation is actually felt. And you see this is anastomosis around the ankle joint once you have done these arteries here. So when you take up any artery, watch, name the arteries of the entire region lower limb, surface anatomy of the artery. You see whatever arteries you are actually pronunciating, you should in fact will locate these arteries where in the body you find these arteries, and where exactly the pulsations of some of the arteries which are palpable. On surface you have to feel the pulsation, and anatomically you have to tell here where you feel the pulsation. Theoretically you will actually talk also. It is not that you say that I can feel the pulsation here. No, here is not actually a thing. You have to see, you have to tell that in a particularly in a theoretical way where it can be felt between which tendons, like here. So here, and whenever you take any artery, arteries should be taken just like the muscles are taken, like introduction, origin, insertion, nerve supply, actions, blood supply. Here they are taken, each artery has to be taken here, introduction, where it begins officially, at which point, what will be its course and relations, in which intramuscular space it passes, and what other structures are actually having making relations with them. Where it finally will terminate, arteries do not terminate, they will change their names, or they will bifurcate, or termination will be by bifurcation. So this is where they will terminate, and what are their branches. Count the branches, and during their counting of the branches, if any major artery will be one of their branches, again the same headings will be on that artery. The branch of that artery, because we have got 7 branches for example, but out of these 7 branches, one branch is very large. So we will take this branch and will again discuss that branch under same headings like introduction of that branch, beginning, course and relations, termination and branches, and surely after that some clinicals also. And after that you have to see the veins, and in the veins again the same means here will be go back here from foot backward here, this is called dorsal venous arch. After dorsal venous arch, two veins will emerge from dorsal venous arch. One is called the great saphenous vein, another is called the small saphenous vein. And then after that you see in the leg we have the deep veins also. These are superficial veins, but we have deep veins, we are called them the venae committents. And then we have deep veins. After the venae committents of the leg, they will join together to form the popliteal vein, and popliteal vein will continue to become the femoral vein, and the femoral vein will leave the thigh to become abdominal vein, that is called the external iliac vein, that will join the inferior vena cava. So these veins are there just like arteries. Name the veins of the region, superficial and deep here. Surface anatomy of the vein, you feel that vein which you are actually talking about, and then take each of the vein and you discuss them under the headings like introduction, beginning, course and relation, termination. Tributaries, this time the vein does not have the branches, they have the tributaries because blood will pour inside them. It is not distributed, that is why we call them tributaries, and then the clinicals. After that, the lymphatics. In the lymphatics, we do not have too many of things. We have got a group of lymph nodes, that is called the superficial inguinal lymph nodes. We have the deep inguinal lymph nodes also. You see deep inguinal lymph nodes within the femoral triangle. Then we have got popliteal lymph nodes, few of them, and all these lymph nodes you have to see here. And these lymph nodes, various groups of lymph nodes you have to locate, their surface anatomy, where exactly it is, and then name of each group of the lymph nodes, where they are located and what is the area is drained by them, which lymphatics in the which area is actually going inside them. After that, you will enter into the nerves. Nerves means you have to deal with the nerves, not just the nerves. Nerves will be actually dealt with and will be described just like arteries. But here, which nerves you are taking? The nerves which you are taking, but to watch the plexuses first, because all the nerves of your lower limb, they come from plexuses. So, lumbar plexus to some extent, sacral plexus, their union, lumbosacral trunk, this is called lumbosacral plexus basically. And then you will come back, you will watch the nerve, that is the first nerve you have to take here, is called the femoral nerve. Then in the gluteal region, you have the superior gluteal, you have the inferior gluteal, and in this region the pudendal nerve. In the gluteal region, again the nerve to obturator internus and nerve to quadratus femoris. You have the posterior cutaneous nerve of thigh, and all of this you see the largest of all the nerves in the body, in your body, it is the sciatic nerve. And then the sciatic nerve, you know that in the popliteal fossa, just before popliteal fossa, it splits into the tibial. So, you watch the tibial nerve again, and tibial nerve continues and will back of the ankle, you see that on the medial side of ankle, it will divide into medial and lateral plantar nerves, just like arteries. And then the sciatic nerve was not just having the tibial branch, but having the common peroneal branch, you have to see here. And common peroneal, where the word common comes means it has split into the two things here. One is called a deep peroneal nerve, which is the anterior compartment nerve, and what is called superficial peroneal nerve, this is the lateral compartment nerve. Tibial was posterior compartment. So, superficial peroneal nerve, lateral compartment nerve. And whenever you take any nerve, again name of the nerves in the region, surface anatomy of each nerve, feel that, introduction. You take each nerve now, introduce that nerve, beginning of that nerve, from where it comes, what is the root value, course and relations, termination and branches. And during branches, if it is the most important, if the main branch comes or the big branch which is actually has to be dealt with separately, again introduce beginning, course and relations, termination and branches again. And then the last segment that you have to take here is the joints of the lower limb. And joints of the lower limb, you know that you have to do the hip joint, bring the knee joint there, ankle joint, proximal tibiofibular joint, distal tibiofibular joint, then the subtalar joint, very important, and this is and some other small joints in brief you have to take. And at the last you have to do here the arches of the foot also. And you see, when you are taking the joints, for example, name various joints of the region, do the surface anatomy, and in each joint these 10 headings are actually given here. Introduce that joint, what are the articular surfaces which are contributing to form that joint, what type of a joint is it, how the capsule is surrounding this joint and where is the attachment of that capsule, what is the synovial membrane, there is ramifications, how these ligaments support the capsule from outside, maybe intrinsic, maybe extrinsic, intracapsular and extracapsular ligaments maybe. Then what are the bursa, we will tell you that synovial and non-synovial bursa around the joints. Then are the movements, what type of movements are present here in the joint, what are the nerve supply, the nerves which supply the joint, maybe the blood supply also important. At the last will be the clinicals. So, every joint in your body has to be, synovial joint especially, has to be discussed under these 9-10 headings, and even some relations you can write here. Understand, this was the first phase, anatomy basically. After that is the second phase, there is clinical correlates of all the regions, all the segments, bones of the entire lower limb, clinical correlates, what problems like fractures, etc. Skin and fascia, like in femoral sheath, there may be hernia. Muscles, muscle strains and other things, rupture, everything. Spaces, what are the neurovascular bundles in that space, are any problem like in popliteal fossa, there is Becker's cyst or anything. Arteries, aneurysms can be there, their rupture and everything. Veins, their varicosities. Lymphatics, their enlargements, lymphadenopathies will be there. Nerves, their paralysis and their injuries. Joints, dislocation, etc. So, these are the segments you have to deal with the segments in which you have to do the second phase of the study. After you have done and good knowledge about the basic anatomy, you have to go into the clinicals. Do not do the clinicals during your phase 1, it is not required. In the second phase now you have to deal with them. And the third is the BCQ practice. of all the regions separately, bones BCQs, skin BCQs, facial muscles, spaces, etc. all the BCQs, and the last will be the case presentation. I have already told you that in case presentation the case must be related to the pathology of the bone, maybe bone fracture the patient comes to you. So, this was actually your class, and this is the way you have to take all your lower limb, all your lower limb has to be actually taken like this. So, by now it is not just this region, lower limb is a very easy region, you see go through that region and you will actually be used to take a region how to take with them. And if you take with this region, the other region will be basically it will be very easy. So, overview I will tell in the other regions also the overview, but the method will be same. In overview I will tell you that these are muscles and the compartment of your upper limb will have the forearm, arm, forearm, hand, it has the palm, it has the dorsum, the same, the way is same, the things will be different. So, overview I will tell you that in the palm what you will take in this also here, in abdomen, in these things you have to take these things like this here. So, this was your class today.